any questions that have percolated? I went and I looked at the on the way back from the restroom, the ads in the hall for research to see if any of them mentioned a dollar amount. I noticed one said that you might be eligible for compensation, but was otherwise tantalizingly vague about what that was going to be. Thoughts? No? All right. You tell me if you have new thoughts.
I think ours says compensation is available, and I don't like that because that's sort of iffy.
Right. So the comment was that their poster says compensation is available, and that sounds weird. Like, well, who's it available for? I would like compensation. If it's not available for me, enjoy your research, you know. That is interesting. That's something that hadn't really been on my radar. Now I'm gonna look at it. Like, why would it say that and not say compensation will be provided for those who are, meet the eligibility criteria? What's wrong with telling people that? For transparency. So interesting. All right, we're going to talk more in depth about demonstrating respect for our research subjects, which are complete, uncoerced, and understood. I will say that coercion is on our part. Part of my job here is I don't only wear a research ethics hat, but I also have a clinical ethics hat that I often wear. I have my finger in many pies, Jill of all trades, master of none. Anyhow, oftentimes in medical care, people say, oh, this person's being coerced because their family wants them to do it. We're not really responsible for if people's family wants them to do it. People have pressures on them from a variety of different angles. Just because someone has an external influence doesn't mean that they're so coerced we shouldn't allow them. If someone's like, husband, wife, sister, brother, adult child, oh, I really want you to participate in research, and they say, okay. To a certain extent, that's not our problem as a researcher. You know, if they have the beginnings of dementia and their adult child is bringing them in and saying, he says yes, and wedging a pen into his hand, that's a problem. If people are just in their everyday life have some influence from family, well, don't we all? So coercion is from our perspective. Is that happening on the part of the researcher, or do we see a family member who's really pressuring a patient who's unable to resist? We have to protect our vulnerable populations. We've talked about who those are. Must not use coercive advertising. I wonder if this is part of the compensation, if we think like, join now, let us shoot you up with this toxic waste and we'll give you $1,000. Like, that seems unsavory. All right. Okay, so consent versus informed consent. Generally, we know that if we talk to patients or subjects and we say, do you understand? What will they say? Yeah. Uh-huh. Do we think as many people understand as say, uh-huh? No. No, I've done it before. People say, are you understanding? And I'm like, sure, of course I am. So consent is when people do that. Do you have any questions? No? Fine. That's not the same as informed consent. Informed consent is when I'm agreeing because I really understand what you're asking me. I know what the risks and benefits are. The rules are in line with my own personal thoughts and values, and I want you for that reason. I'm not just saying, you're my physician and you take care of me, and I don't want to piss you off, so I'm just going to nod and smile to whatever you want me to do. So in an ideal world, which of course none of us live in, consent is a process and not a product. I really I give a lot of pushback to especially my medical students or residents when I hear them at the hospital say, like, I'm going to consent the patient, because what they mean is I'm going to get a signature on this paper from the patient. They don't mean I'm going to have this conversation about their values and what this involves. It should be ongoing for the duration of participation. It's not just, I've gotten the signature on the form, so done and done. Includes all information a reasonable person would want. This can sometimes be challenging because we're all reasonable and unreasonable in our own ways. There's a famous ethics problem you've learned in graduate school that's about a patient who He has a choice between a low-risk procedure and a high-risk procedure. But the low-risk procedure might result in some loss of sensation in his fingers. And he chooses the high-risk procedure, and Evan's like, well, he obviously does not understand. He doesn't have full, he lacks capacity. Let's get psych in here. And it turns out, well, it's a patient that's a concert pianist. So that maybe what's material information for you and I, and we're going to choose something an easy procedure, and if we don't have full sensation in our fingers, that will be unfortunate, but we'll live. But the material information is different for someone who makes their living out of how sensitive their fingers are. So it's hard to say, well, we have to list every possible thing in the whole world on a consent form, because number one, that just increases the chance that no one's going to read any of it. And we want people to read it. So it's hard to say, well, what will a reasonable person want? So we try to do what is best for the most amount of people. It requires language understandable by the individual participant. We do a super terrible job in this. What's the average reading level in Arkansas? It's 8th grade nationwide. What's it in Arkansas? 5th grade. So 5th grade is when you're at your very best. Are you at your very best when you are at the hospital? I'm certainly not. I'm stressed out, I'm pressed for time, maybe I'm feeling sick, maybe I am sick, maybe I want to impress my doctor. So at that point, what maybe level do I need to read at? Maybe 3rd grade. The general rule at UAMS is 8th grade. We don't enforce that very well. And even if we did, that doesn't work for a large number of our participants. So that's something that we're always working on. We share office space, medical humanities, with the Center for Health Literacy. Please get them involved if you need help getting your consent form down to a lower language level. Because a lot of people are not going to ask if they don't understand, and they're just going to consent without giving informed consent. And remember that, unfortunately, Arkansas is a state with low literacy, especially low health literacy. It includes the opportunity to ask questions at any time. So the essential elements is that you're giving consent voluntarily, free of coercion from at least our perspective. You have enough information to be able to make a meaningful decision. And this includes disclosure. I'm telling you all the risks, benefits, pros, and cons. Recommendation, it's okay, especially in the clinical realm, it's okay for a medical professional to give you a recommendation. That's not coercive. They have knowledge that we don't have. What's coercive is them saying, because I have knowledge, you have to do what I say. And understanding. I could say, I understand what you're telling me, that you feel this is the right choice, and I've decided it's not. And the patient has decision-making capacity. Capacity is generally, capacity in Arkansas is evaluated by a physician. Generally, if an adult comes in and appears with it, we're going to assume they have capacity. Capacity is not all or nothing. You can have capacity for some things while at the same time lacking capacity for other things. You might, if someone has a little demented or has been sick or just had surgery, they might have capacity for things like, would you like an oral medication or an IV medication? While not having capacity for things like, is it okay if we do an open heart procedure on you? The other thing to know about capacity is it fluctuates throughout the day. So I think sometimes we think it's going to be really obvious. This patient lacks capacity and this patient has it, and it's not as simple as that. If you have, when in doubt, stop. Speak to the PI, maybe have the patient come back another day. So what makes consent, oops, I pressed a button I haven't pressed before, that was exciting. So we've talked about this throughout our time together so far. In order for consent to be informed, what does the consent form need to include? It doesn't need to be a form. Really, a verbal consent is just as good, as long as it is deliberate and contains a lot of good information. What is the nature of the proposed study? None of this happened in Tuskegee, but they didn't say, look, we're interested in studying the natural course of syphilis. We're going to do that by looking at some people with syphilis, like something like that. Just what is this study about? Why am I asking you to be in it? What are the expectations? what's going to happen? What are the potential outcomes? What are the alternatives? It might be, well, the alternative is just not being in research. The alternative is going on another chemotherapy from your doctor. And the subject should be informed about the known inherent risks that are material to the informed decision. I hate when I step on my own slides. I already told you a little bit about capacity. Oftentimes in the hospital, I hear people talk about both competency and capacity. These are not quite the same, although often when you lack one, you lack the other. Competency is all in the realm of the courts. So in the hospital, unless we have a document from the courts, we should never be talking about competency. That's just not what we do in the medical realm. It's a legal status. All adults are presumed competent until a court rules otherwise. The courts are the only one that can declare you incompetent, and it's realm specific in terms of, like, you're going to lack competency for all of medical decisions or all of financial decisions. Whereas capacity, which I explained a few minutes ago because I got in the way of myself, is a medical status. Any licensed physician can make a capacity determination. That is an Arkansas-specific law. If you go to do research in another state, check your local laws. Because some states will let a PhD psychologist, things like that, also evaluate capacity. That is not the rules here. Here you have to be a physician, but you don't have to be a psychiatrist. You can be any kind of physician, licensed physician. It's task-specific, like I told you a few minutes ago. You can have capacity right now for some things and not for others all at the same time. Any questions about competency versus capacity? Who can consent for research? Can someone who lacks competency? No. Can someone who lacks capacity? This is what I heard when I asked the question. Mom? Anyone want to weigh in? You need to have, if you lack either competency or capacity, you should not be consenting for things. Unless, you just lack capacity for, like, complex decisions. But usually research is a complex decision. So if we are unsure about someone's ability to make decisions for themselves, to understand information, that is not a good research participant. If it's temporary due to that they just had surgery or whatever, you can try again. But if definitely anyone who has a documentation of incompetency, no, you need to go to their decision maker. Capacity, if it's a patient who's questionable, I would say to be on the right side of ethics, you should not be consenting them either. Questions? No. So beyond consent, special circumstances, I talked about this a little bit earlier. There's a time when people ask for waivers of written consent, and there's times when it's completely ethical and appropriate to not get written consent. One of those is when the only paperwork we would have telling me your name and that you participated in research is the consent form. That doesn't mean we're not going to get consent from you. It means we're not going to document consent for you. And the reason we're not is because it opens up more ways that we can violate your privacy to have a written consent than to not. Because then we'll have your name and information all written down. Again, that doesn't mean we're just going to not tell you things. It means that I'm going to just discuss it with you and we aren't going to have to document and get your signature and things like that. These are usually studies where the principal risk would be potential harm from a breach of confidentiality. Like, I'd like you to fill out my survey about shapes of Tootsie Rolls and what's best. It's not really harmful to me. You're still going to tell me the risks and benefits. But if it's not like a written signed consent form, we're not very concerned about it because the risk is so incredibly low. I mean, maybe I'll get a cavity or I will feel ill because I ate a lot of shapes of Tootsie Rolls. But you know what? Sometimes that happens with adults. There can also be time, one study I took part in was in terms of giving, we wanted to give subjects some payment for their time. And in order to give subjects payment, we need to collect personal information because of tax rules. And so in that case, we said to to the participants. We are happy to give you a gift card. If we give you a gift card, we are going to have to take down your name and address and your social security number because we have to for tax purposes. It's up to you. That's the choice, and that's a reasonable choice to give people. They can choose which value is more important to them, to have the gift card or to totally be unidentified in the research. Also, there's times where we allow a waiver of written consent because we're doing something that we would not need informed consent for outside the research context. A lot of my research is actually about consent, so I often ask for a waiver because to have someone fill out an informed consent form, to read my informed consent form, number one, is irritating to all involved. Number two, outside of research, I don't say, I'm going to consent you now. Before we talk about consent, I'd like to consent you to talk to you about the consent. Like, it's just not what we do. So those are all times that it's completely appropriate to get a waiver of consent. Again, we're still talking to the subject, we're just not having written documentation. Any questions about waivers of consent? No. Okay. There's also waivers for emergency research. Because there are times that we want to study things, and I'll give you a case study in a minute, where we want to study certain procedures that will only be used in an emergency setting. And sometimes the only way to study emergency settings is in emergency settings. A time when it is really hard to talk to people about their participation in research is when they've come in with an emergency, when they have car accidents, when they have a gunshot wound, things like that. We know it's not a time to say, have you thought today about research? So there are times that we allow a waiver because we say, you know what? We want studies about better ways to care for trauma patients, and the only way to do that is by studying trauma patients. Generally, there's some community oversight. We have community boards with sort of members from the general population that will talk to us about whether this seems appropriate rather than talking to each potential participant as they come in. I'll talk more about pediatric consent. There's this own section of the Common Rule. It's within the parts about vulnerable populations in terms of how we consent children. So speaking about emergency consent, are there ever times that consent is unnecessary? This is another ripped from the headlines actual case. This is a case study of, it's not even a medication, it's sort of a substance called Polyheme. Polyheme is a blood substitute. Thanks to an unusual loophole in the strict rules of medical ethics, hundreds of trauma patients in California, Texas, and a few other states will be taking a gamble when ambulances come to scoop them up after accidents or acts of violence. Without waiting to get consent, paramedics will inject a fake blood product, which is Polyheme, into half of the eligible patients chosen to take part in a new study. The other half will get a routine treatment of transfusion with a saline solution until they reach the hospital, because generally there's not pints of blood on an ambulance. So no one's getting blood, which is the standard of care. Some people will get the saline, and then some people get this Polyheme, which we're not sure might be better than saline, might be as good as blood, we just don't know. If it's better than saline, or even better than blood, this could be something really excellent for treating trauma patients. Do you have any concerns about this research so far?
Has it had any animal trials?
Yes, it has gone through the regular steps of the animal trials. Good question. We have reason to believe that there is promise in Polyheme. There's science behind it, there's animal models, but we still are not sure, but we're not just making it up. Yes?
That's approved by the FDA?
It was approved by our IRB for research. It's not an approved treatment yet because we don't have full human subjects research behind it. So the FDA, we're not at the FDA step yet. Thoughts? Any other? Are you troubled? Does it seem okay?
I don't know how I would feel about getting something that I don't know injected into me.
We're not gonna ask you either.
Because you're taking a gamble. Just the wording, taking a gamble.
I know, I don't like, this is from a Wired.com. It's, I feel the wording is, inflammatory.
Yeah.
Also, when they talked about the loopholes in medical ethics, that's not it's not a loophole, it's that we allow research on, for emergency purposes. Because otherwise, we might not know. Is this a case where it's acceptable to try an emergency situation? Do we have other options?
I guess if one means that you have the same chances, like everybody was selected equally, and that doesn't come across.
We're gonna have some, pardon?
Who decides?
There was some sort of randomized way where there was numbers assigned, and like to every fourth patient or something is going to get who is in a certain traumatic state. So it wasn't just, let's try it him, that it was randomized in terms of, oh, the next patient is the one we'll try it on. So we tried to make subject selection equitable. Like any patient who's having blood loss and needs a replacement, every third adult's going to get polyheme.
Is it the only way to test it?
What do you think? What do people think?
These paramedics don't know anything about the medical history of this person that they're carrying. And
Nope.
they have no idea what kind of reactions or risks are going to happen.
That is true. So should we not do it? Think about it. Yes, go ahead.
Usually there's a policy on emergency use, but mostly they will approve when there's a science behind it.
Right. So there is.
Tested by Inhuman, but they will take the risk anyway, you know.
Right. So there's a time where we approve things for emergency use and when they have science behind them. So we're sort of at that step, like this needs some research behind it. Is this the best way? Is this the only way? Is this an acceptable way?
Is there criteria for who needs the treatment?
The question is there criteria for who will get the treatment? Yes, there is. Like there is an IRB proposal at least that will say something like, here are the clinical indications for patients we want to give it to. It's not just going to be random, that they'll need to have a certain kind of trauma. So in the trial, polyheme is given to patients without their consent in ambulances where blood is not available. Some patients also get the blood substitute for up to 12 hours in the hospital where blood is available. Ethicist Nancy King says some patients who die from their injuries will perish while being denied an available treatment, a standard of care. Though she favors concept of waived consent trials, she says polyheme could be tested on the battlefield or during elective surgeries in which you could get prior consent. Do you agree with the way the study was run? There's also a lot of community work, I should say, before this was done. Part of the reason that we want to develop blood substitutes is not only for emergency situations, but for Jehovah's Witness populations. So there was a lot of talk with the community about that. There was an opportunity offered people in the community, like if you know you wouldn't want polyheme to like wear a bracelet, but a lot of people aren't willing to wear a bracelet because everyone thinks, oh, I'll never be in a trauma. That seems silly.
But it sounds like, so some of the people that were given, if they were given the blood substitute for 12 hours, once they were in the hospital, when blood was available, then they could die as a result of that, where they didn't consent to the study. And so I think it seems like they should do a different protocol.
Okay.
That, because again, there's a large risk.
Okay. You say it's reminiscent of Tuskegee.
Yeah, I mean, there's another option available that we know is scientifically sound, and yet they haven't been consented, and they're given this thing that they don't know about. And
So we have a standard of care, which is to give people a pint of blood.
yeah,
then there's times where we aren't able to do the standard of care, like in an ambulance. But here we're also talking about once you've arrived at the hospital,
When you're denied that standard of
you're
care,
being denied the standard of care.
and that's not ethical.
I think it's pretty troubling, yes, because generally we don't allow people to not have the standard of care in research. That's part of what we were talking about the children in the hepatitis study. And part of that is we don't allow people to be infected for research. Even if they agree, that's just not something we allow. And by the same token, we just don't allow people to not get standard of care. That's not appropriate to ask people about.
Right. And like Ethicist King says, there are other ways to do this, to test it.
Right, so that's part, I think, so are there times when having a consent waiver, doing emergency research is ethical in general? And was this one of those times?
I think there are, but I think for that reason that this one is not.
Okay, so the comment was, there are times when it is ethical to do emergency research, but this was not one of those times. So I see general agreement on that. I tend to agree, and I'm not even so troubled with doing it in the ambulance because we are truly unsure there if polyheme was better than the saline. We know saline is not the best it could be, but we know giving people blood is a really good option. And it gets back to, are there alternatives that we could do to learn this information? And yes, look, she's suggesting alternatives. We could either say, you're going to fight in a war, and unfortunately, it's more likely that you will receive a trauma than other people. Are you willing to have us try this on you? Or, hey, you're coming in for elective surgery. We're running some research. We have time to sit down and talk to you about it. We're going to talk to you about, would this be okay with you? And I think even in that case, I'd have to know, do you usually give blood then? Do you usually give saline? Are you really unsure if polyheme is better than blood? Because again, that might be asking people to not have the standard of care. But so there are other ways to do it, I think is part of why this did not go well. For just FYI, polyheme was found to not be very successful. It's something we don't use now because the studies did not bear out it being even better than saline. So I always like to know what happened. So they did run the studies. I think they even had to end some of them early because they were starting to get information that polyheme was not going well. So who should be allowed to consent for research? We generally know that as an adult with autonomy, you can consent for yourself. You can make decisions we disagree with. That's part of why we don't allow poor research studies, because you shouldn't be allowed to consent to, like, have your arm cut off or things like that. Should the regulations be different for consent for yourself versus consenting for your child or your adult ward, say your sibling or your spouse or your parent who lacks capacity? So what do you think about that? Should I be able to consent for my child or, you know, my spouse for any research I would enroll myself in? Does the risk level matter? Does the potential benefit? How about the prevalence of the disease? And are there types of research that I should really only be allowed to enroll myself in and not others I'm consenting for? People are thinking. Is there a difference? Because generally, if there's an approved study, and I'm an adult and I seem as with it as people generally are, you're going to be like, well, all right, I'll explain it to you and you can choose. And we for good or ill, we agree that that should be allowed. Is that just the same as if it was for someone else? Does it matter how risky the research is? Should there be different rules if I'm enrolling myself in something very risky versus my developmentally disabled sibling who's 30 years old? How about the potential benefit to that participant I'm enrolling? or how common the disease we're studying is. You know, what if you're studying a disease like Jesse Gelsinger had, and versus you know, influenza. I heard that there's some thought that risk levels should matter. Other thoughts?
Even the benefit actually would be, what if that person who is consenting for another person, what if he or she is just doing it for the money aspect of it?
So the question was, what if I'm consenting for someone I'm the guardian for, and I'm just doing it because I want the cash. Like, no skin off my nose if they're uncomfortable, whatever. Like, I'm still gonna get $50. That would be nice. And what about vulnerable adults with capacity? You know, your prisoners, your pregnant women. Should we be allowed to do the whole, all types of research with them as well? People are unsure. I think it's important to think about. We're also going to talk about children in terms of, are we studying something that might benefit the potential participant, or maybe will benefit people who are similar to the participant, versus just we need participants and whatever, you're here for your regular checkup. So a far more dependable safeguard than consent is the presence of a truly responsible investigator. And I'd also include study staff, study coordinator, team members. This is another quote by Henry Beecher. But even fully responsible practitioners, investigators, teams face difficult decisions when lines are unclear, values difficult. I hear a lot of questions here at UAMS, research ethics questions, and it's not that everyone who asks me a question is a horrible person who doesn't care about the participants. It's that sometimes these are really gray areas. Even now, like when I just asked, should we allow, what kind of research should we allow people to consent their wards to? And it's a hard question. On the one hand, you think, well, you're the decision maker for your family member. You know them better than I do. You know, maybe they used to have capacity and they've talked to you about what their values are. So maybe I should really defer to you. On the other hand, as a researcher, we have a special obligation to protect the people that we are enrolling in our studies. And should I not allow it, even if you want to, because that's interfering with my own obligation of protection. So again, I think it's easy to think of, oh, I would never commit any sort of human subject violations because I'm not a terrible person, but a lot of it's gray area, and so it's hard to say. So what constitutes research? Again, I spoke of this earlier. This was in the Belmont report, and then it's also echoed in the Common Rule. So what's general therapeutic practice? We spoke about that earlier. Anyone want to say? That's when we have an intervention. We think it's going to benefit you, and we have science to believe that. That this is a well-studied intervention. It's meant to treat the problem you have, and so I'm going to give it to you. Experimentation is, this departs from standard accepted practice, and it's new and untested. I have reason to think it's going to work, but I don't really know. And I'm just going to use it for you or maybe 2 or 3 patients that I don't have anything else to offer. First is research. We're going to contribute to generalizable knowledge. We're going to test a hypothesis. We have a whole procedure. And so the Common Rule echoes that same language. Systematic investigation and generalizable knowledge. So is it ethical to use this innovation? I keep mentioning this sort of one-off, and is that something we should allow? Because it's sort of in its own land of non-regulated behavior. So innovation is an ethical success. We allow it when there's no existing proven therapy. The existing practices are suboptimal. Maybe they have terrible side effects. Maybe they're super expensive. or therapeutic alternatives are in equipoise, meaning we truly don't know which one is better than the other. None of them really are. There's nothing great. Physicians are using their best clinical, and this innovation sort of thing, this happens a lot, say, in patients with cancer. We're going to try an off-label use, or certain patients who have refractory mental illness. Like, I really want to help you, and I have nothing else that has been approved for you, and I'm going to try this. If a physician's saying, like, look, I've read some studies, I have reason to believe this, this is my best clinical judgment in light of the evidence, it's okay. We need to get informed consent of the patient, the parent, or the surrogate. They must be told, like, look, I don't know, I'm trying this. This is an experimental time. I don't have science to show that this is going to work. And that a reasonable effort to create a research protocol is developed in a timely manner when applicable. Because, of course, the big concern about this is that I'm going to just use a lot of these one-off innovative experiments instead of putting together my own IRB application because it's easier. Because I don't have to get a bunch of money, I don't have to do all that pesky writing, I don't have to deal with the ethicists on the IRB and all for darn questions, that I can just give this to individual patients. And so when that gets to be a pattern, that's a concern for us. We don't want to be a pattern of physicians doing that instead of doing good, rigorous research. Because it's a balance of issues with innovations. The good is that this is patient-centered care. We're all about patient-centered care. And it's also a form of practice. This is how you get an idea, how you use it on your patient, and then it hopefully will become standard of practice. Like, oh, I had this idea and I tried it. It worked really well. It can move the practice forward more quickly. If you have one patient who's dying and you want to try a type of chemotherapy, you don't always have time to put in a whole IRB application. The cons are that there's really no regulation or oversight. Only the oversight is if a patient chooses to use the legal system to sue the physician afterwards. This wasn't approved. You should have known it wasn't going to work. You shouldn't have experimented on me. And it does not follow evidence-based medicine, which is another thing we're all about. And then it can turn novelty into standard without warrant, where you say, oh, this one physician always is prescribing turmeric for strep throat. They've found turmeric, that they like it, and so it's his standard of care, even though there's no real reasoning behind it. It just has gotten to be the thing that physician does. It's also difficult to explain potential risks and benefits because you don't really know them. You say, well, I'm hoping for the best. I have a little bit of reason to think it's going to work, but who knows? Might not. Might have terrible side effects. So why not turn to research? Why do you think physicians don't turn to research? I've given you some of these answers. Time's a big one. Funding, also a big one. There are not enough people giving us stacks of money. I have that problem with my own research. So the good part about research is then this is generalizable knowledge. If you did something in Boise and it really helped your patient, I want to do it here in Little Rock. I can't do that unless you do a research study and then publish the results to it. Otherwise, I don't know what you're doing. There's regulation and oversight, so we see you're not taking advantage of your patients. Follows evidence-based medicine. The cons are that it's slow. It can slow progress when we are just trying it one-off instead of publishing it so you can do it too. It can be difficult to be ethical when you just have this idea and you're trying it without really having a long consent form or evidence-based medicine standards. So is the distinction between research and innovation, is this important? Is this something that is meaningful to subjects? Or is this just meaningful to those of us who like to look at regulations because we're strange? So drugs and devices are all approved for specific uses by the FDA. Every medication all of us take is approved for specific use. That doesn't mean it was given to us for a specific use, and I'm sure some of us have had the problems of, oh, my insurance would pay for this if I was getting it prescribed for earwax, but they won't pay for it because I'm getting it prescribed for my fingernail problems. Certainly there's a lot of off-label use, but they are approved. Sometimes you'll hear like, oh, this medication has newly been approved for treatment of blah, 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 even though it was always already approved for treatment of something else. It's totally allowed for physicians to rely on their clinical judgment about using it for a different purpose. Again, there are certain fields of medicine that this happens really commonly in, mental health being one, some, difficult to treat cancer being another. How much innovative use is acceptable before a clinical trial becomes necessary? Again, we want physicians to innovate because sometimes that is what it takes to get new knowledge. But we don't want physicians to just become used to using innovation instead of systematic research. It doesn't give us good results. It doesn't give results that people elsewhere in the country can use. So that we don't want physicians to rely on that as their standard practice. But then it's a question, well, how many innovative surgeries should they be allowed to do before we say, look, no more unless you do research studies? You've done 3, you've done 5, you've done 50. What is too many? I don't know. Again, the mechanism of control is not through our regulatory system, it's through our legal system. This is the only way, if you feel you've been wrong through innovation, is to bring a lawsuit. So do you think this is an important distinction? Is it meaningful to patients? People are unsure. I hear some people saying, I don't know, it's kind of important as long as there's no follow-up questions. I do think as a patient, I would want to know. I'm not saying I would say no to either one. I think there's times where you would say yes to either one. But there are times where a physician might say, look, I don't really know, but I think it might. And I say, well, all right. Or I might say, meh, that's not good enough for me. I want something that is evidence-based. So there's a big problem, something that I think we don't pay enough attention to, is the conflicting role between clinician or researcher. Time to tell one of my other rips from real life research stories, which is that I'm a migraine patient, and this was not, and I'm not making this up, not at this hospital. But so whenever I go see my neurologist, there's like 100 forms, like how many headaches have you gotten in the last month? What part of your head is the headache on? What kind of foods trigger? Like, I don't know, there's a lot of stuff when you have migraines. So I'm filling out all the stuff because, that's what they want me to do. And as I'm in my big pile of forms, I notice there's a consent form for research. And so I'm a crank, so I set that aside, and I filled out all the other things. And I come in, the nurse brings me into the room and says, have you filled out the forms? And I said, well, yes, I have filled out all of the forms except for the research, one about research. No one has spoken to me about research, so I did not feel comfortable filling that out yet. And she says to me, I'm going to have to tell the doctor you did not fill out all the forms. So I'm straying from the microphone. I'm going to have to tell the doctors you didn't fill out all the forms. So if you heard that from your nurse, what would your response be? Let's say your job is not to be a crank in general, like mine is. You would feel the need to fill it out. I think if I wasn't someone who worked in research, I would not have noticed that it was not something for my own care. It would just been in the form, and I would have just filled it all out. And then even if I had set it aside, when she said, I'm going to have to tell you the doctor about it, I would have been like, oh, crud, I better fill that out. Because she's going to tell the doctor on me. So that's an example where there's sort of a conflicting role, because I'm there for my own clinical care. I've not been approached about research. No research has been, I haven't been told the study staff's going to talk to me. I just am there for a clinical appointment and something else is happening, which I just realized because I have this tiny bit of knowledge from what my day job is. Otherwise, I think it's like, I'm not saying I'm smarter than other people, because there's times in my life before I did this job I would not have noticed it at all, because it's not what I'm expecting. I'm used to filling out a big passel of forms there. It's just, I wouldn't have given it a second thought. And, and people who fill it out, it's not just, oh, they're so stupid. It's just, you have to be attuned to certain things. So the goals of medical care and research are different. So what would be the problem if I had just signed it? I mean, I'm a grown-up, I have autonomy, they didn't, you know, what's wrong with it? If I just filled out the whole stack of forms, including the research consent? Or was there no problem, and it was just my crankiness?
No one was there to make sure you understood it.
No one was there to make sure I understood it, that is true.
No one was there to answer any questions, if you had questions.
No one to answer questions. What do you think most people who filled it out thought about it? That it's part of the clinical care, standard of care. This is needed for their care of me. So the roles of the clinician and the investigator are different, and so the potential conflicts of interest arise when the investigator and clinician are the same. I'm not saying like, oh, that was terrible research, but it was not presented to me as this, here's your stack of papers about your headaches, and here's about us researching other people. We would like you to contribute to the generalizable knowledge. That it wasn't clear to me that it was, part of it was voluntary and part of it was not. And of course, the way the nurse approached it did not help. Yes?
Is the PI that research form your doctor?
So it was it was a neurologist in that group, but not my personal physician. Because being a crank, of course, when the nurse said to me, I'm going to have to tell the doctor, I said, you go right ahead. And then when the doctor came in, I told him, like, look, what's going on here? I said it somewhat nicely, but I said, I'm troubled by what is happening here. And he immediately reacted by throwing his colleague right under the bus. Like, well, that's Dr. So-and-so's research and not mine. I don't disagree, but Dr. whatever, Dr. what's-his-face, that's his deal. So it was not my exact physician, but was a physician, you know, in the practice. So anyhow, yes, I think that, again, there's no problem with recruiting at the like, you need people with migraine, here's a good place to find them. But why don't you have your study nurse come in? Or why don't you have it on pink paper? Or why don't you say, hey, Leah, while you're filling out all those forms, would you be interested in taking part in research to help people with migraines? I probably would have said, sure, that sounds fine. So there's lots of ways to do it. But I think especially, again, if I wasn't involved in research, it would not have been on my radar. And I just thought, this is what my doctor needs for my care. And we don't want people enrolling in research for that reason. We want them to enroll in research because they're interested in helping, or any of the variety of reasons people enroll, not just because they think it's a form they have to fill out. Questions, comments? Now, we've arrived at the second cartoon. So let's take, again, until about 2:15 this time, have a break.